in liver failure. Okay, liver failure can be acute liver failure, can be acute or chronic liver failure, and can be chronic liver failure. But acute liver failure itself is further divided into three parts. And those three parts that we should know in acute liver failure is hyperacute liver failure, acute liver failure, and subacute liver failure. Okay, hyperacute, acute, and subacute. And if somebody asks you what is liver failure, so what would you answer? Arshad? How do you define liver failure? She did this whole topic on liver failure. How do you define liver failure? Acute liver failure, how do you define acute liver failure?
Along with coagulopathy, deranged.
There are two things that comes in acute liver failure. At any given moment, if you want to talk about acute liver failure, okay, A, there has to be INR more than 1.5. Okay, there has to be INR more than 1.5, and B, there has to be encephalopathy. These two things are sine qua non for liver failure, and acute liver failure, to call it, patient should have no prior liver insufficiency. There has to be no liver dysfunction. There has to be no cirrhosis. The moment you get cirrhosis into the picture, then acute liver failure, it is no longer acute liver failure. Are you understanding? Liver essentially is normal. Liver essentially is normal. So the classical example that the world talks about is the fact that if a person took a large amount of paracetamol, his liver is actually normal. There is no prior history of having cirrhosis, nothing like that. So that is the classical history for acute liver failure, when a person gets deranged coagulation and the patient has encephalopathy. So that's why in the criteria for transplant and liver failure, they are not looking at those. They are looking at only the pH. That is defined. INR being high and this being encephalopathy being there is defined. So when it is paracetamol poisoning, you are looking only at pH. pH less than 7.3, that patient is a candidate for transplant or movement to a transplant center. Clear? Acute liver failure is clear? We just
even if underlying this thing underlying fatty liver is also there.
No, you cannot have anything. So fatty liver is not something that will. I'm not very certain whether if you put fatty liver, what is it? If you put fatty liver?
Fatty liver doesn't cause acute liver.
Fatty liver is not causing acute liver failure. You are saying if there is an underlying liver failure and background. Okay, so when we are saying liver dysfunction, you should have a dysfunction, no, somewhere. Fatty liver may not cause dysfunction. It is just an entity. It is just a ultrasound or a fibroscan entity. You understand a fatty liver? It is not dysfunction.
If it has caused some derangement,
there has to be liver dysfunction. If it has caused liver dysfunction, means it has gone beyond a fatty liver. A fatty liver, I can have. Any obese person can have. I'm sorry, I've pointed to you. But yeah.
No, even I had.
Yeah, so fatty liver can occur to anyone. It can occur to anyone. But you should have problems with respect to fatty liver. My son tells me, don't body shame me and all this nonsense he started. My younger son. It's some new term, body shaming. I don't know what it is. So fatty liver can occur to anyone, but fatty liver associated dysfunction has to occur. You understand? And that dysfunction is INR.
Not OTPT, not.
No, dysfunction is INR. Okay, I will come.
OTPT will not come under.
No, that doesn't come only. When she showed up the criteria, where is OTPT there? OTPT is a diagnostic tool for you to understand whether this is alcoholic liver disease or something else actually, or it is some ischemic liver disease, or is it something else. That is, OTPT is a diagnostic tool. It is not really anything more than a diagnostic tool. It doesn't tell you anything. It doesn't tell you about the synthetic functions of the liver. It doesn't tell you the coagulopathic functions of the liver. It doesn't tell you. It's just a diagnostic tool. If AST is more than ALT by 1.5 times, this is more often alcoholic liver disease rather than otherwise. That's what you say. If the AST is more than 500, ALT is less than more than 300, it is less likely that it is alcoholic liver disease. It cannot be 500 and 300. It cannot be that high. Okay, so it's not alcoholic liver disease, alcoholic hepatitis. It is not that. So it's a diagnostic tool. AST and ALT is a diagnostic tool. Okay, it's not going to alter any management per se with respect to your transplants. Okay, now when we come to acute liver failure, we further divide into three parts, right? We divide to hyperacute, we divide to acute, and we divide to subacute. And this problem are completely related to the onset of encephalopathy after jaundice. Onset of encephalopathy after jaundice. So, if I have jaundice, and then I'm still not related to anything further, and I get encephalopathic within 7 days, I would call it as hyperacute liver failure, which has got a very good prognosis when you compare it to subacute liver failure and acute liver failure. The worst prognosis is for a subacute liver failure. When you say subacute, it is beyond 4 weeks. So jaundice, and then 4 weeks later he develops encephalopathy. That would be called as subacute liver failure. I don't think you should write and all. I think you should listen. Okay, because it will help you.
It is given in all the.
It's written. All this is written.
Given the vocabulary.
There is no point of.
Different classifications.
Yeah. So the O'Grady classification is something that came out in 2012 or something, 11 or something, and we follow that by saying hyperacute, acute, and subacute. Why do we do that? Because subacute is more like a smoldering course. धीरे liver खराब हो रहा है. Subacute, and that is why वो ठीक भी जल्दी होता नहीं है. That is why it doesn't get better. It's got a poor prognosis. So a subacute liver failure has got a poorer prognosis as compared to a hyperacute and an acute liver failure. Clear? So acute liver failure is in the middle, 7 days to 4 weeks. So onset of encephalopathy from jaundice is the time limit that you take to actually classify a patient into hyperacute, acute, and subacute. Clear on this? Whereas when she talked about acute and chronic liver cell failure, that means patient has got a background liver insufficiency and now has had some trigger that has put him into encephalopathy. Patient has already a liver cirrhosis or liver dysfunction of some nature, and something has occurred in the middle which has caused this patient to go to hepatic encephalopathy, that is called as ACLF, acute and chronic liver cell failure. ACLF or acute. For example, this patient was okay. He developed 5 days of constipation. He had chronic liver disease. He developed 5 days of constipation. He went into hepatic encephalopathy. This is ACLF. For example, a patient who is cirrhotic. He comes to you with spontaneous bacterial peritonitis and goes into encephalopathy because of infection. That is ACLF. A patient who is cirrhotic, he was outside, he had hematemesis and had a GI bleed. He goes into hepatic encephalopathy. That is ACLF. Clear? Clear on this till now? Whereas acute liver failure, patient has had hepatitis, some kind of virus, and he has gone into hepatic encephalopathy. Liver is otherwise okay. Right? So this comes to the question, which are the commonest causes of acute hepatic failure? Which is the commonest causes? So she did mention that, what did she mention? But it's not paracetamol poisoning in our country. Okay. So what you put is basically the United States. In the United States, the first thing is always paracetamol poisoning. The second thing is idiosyncratic drug reactions, and the third thing is unknown causes. Okay, unknown causes, right? So now in India it is the other way around. In India, the primary cause for hepatic is viral hepatitis. It is always viral. And which virus is commonest indicated for viral hepatitis? Please, I'll let one by one answer.
Hepatitis A.
So A hepatitis is the commonest cause of acute hepatic failure in our country. Hepatitis A. What about hepatitis B? Less likely. Hepatitis C, almost not seen. Okay. So when you see all these three viruses, A, B and C, A is the commonest cause, B is maybe a cause somewhere very rare, C almost not there only. Hepatitis C generally doesn't go into this acute liver failure that we talk about. Okay. Apart from these, there are certain viruses that you should be thinking about which are causing hepatitis, acute liver failure, of which one of the commonest is herpes simplex, varicella zoster and Epstein-Barr. Even CMV. Okay, so there is a specific subgroup of patients who basically immunocompromised, and we defined immunocompromised with all those terminologies that we had the other day. You should be sending all those investigations also. So our baseline investigations for diagnosis of etiology when it comes to viral would be HBsAg, which be ABC core antigen, which be IgM, H, A, V, B and C will not work, but you have to include E also into it. Hepatitis E, if the patient is pregnant, that is very common to have acute liver failure. Hepatitis E will always affect pregnant ladies, and those patients or pregnant ladies who are affected with hepatitis E have a very high chance of going into acute liver failure. So whenever you are sending investigations when it comes to, why am I talking to you all these things? Because as an anesthetist, many of you are anesthetists and MBBS people, you all will not remember to send all these investigations. So when I tell workup a hepatitis patient, a ALF patient, this is the investigations that you'll think of. The first investigations are viral, viral investigations you'll think of. Then, if you don't think that there is a viral illness that is there, no preceding illnesses, no pre-morbid condition, nothing at all, then you will also think of other indications like autoimmune. And that is why to complete the investigation, I need to send anti-LKM, anti-smooth muscle antibody, which is a part of the autoimmune profile for hepatitis. Why is this so important? Because the treatment for each of these are completely different. Okay, like an autoimmune person will require a steroid, which you never give for other patients. Clear? Huh? So when I want to do the profiling or the investigations, I will think like this. First I'll think infective cause, then I'll think autoimmune cause. Obviously drug reactions in our country is very high. Which is the drug implicated? Antituberculous, which is the one? INH. So idiosyncratic drug reactions with INH, phenytoin, carbamazepine. These are also drugs that are there which can cause acute liver failure. Okay, idiosyncratic drug reactions, drug-induced liver injury. So there are also idiosyncratic, means any drug can cause, idiosyncratic drug reaction. So your drug pathology, first you're thinking of pathology that's related to infection. Then the next pathology you're looking is drug-induced pathology. The third you're looking at is autoimmune, and the fourth you're looking at rare causes like vascular causes. Now these vascular causes, the commonest cause is Budd-Chiari syndrome, where there's thrombosis in the portal veins. Clear? Clear on this? So that's how you'll probably evaluate these patients with respect to etiology. Okay, it's also important then that if this patient is going to encephalopathy, to grade them. So you grade them by a criteria that she mentioned as Best Haven criteria. You grade whenever, so we said liver failure will have encephalopathy. So if he has encephalopathy, we should be all talking the same language as to what kind of encephalopathy this is. So when we are talking about that language, the language that we talk about is the classification that we use is Best Haven criteria. Okay, Best Haven criteria is there. And what is the Best Haven criteria? Criteria is A, B and C. It's very simple to remember. Okay, what is Best Haven criteria? What is C? Is as a result of cirrhosis. Encephalopathy as a result of cirrhosis. That's C. Okay. What is B? You have it here, इसमें है ना? Very simple. हाँ ना?
Grade 1
So West Haven. So West Haven A, B and C it is. So when I say A, B and C, so I would put it this way that A, C you must remember. C you remember no? C. C, what is C? So cirrhosis on the background causing hepatic encephalopathy. Cirrhosis on the background. So when you say West Haven criteria, C is cirrhosis on the background. That means the liver is spoiled. And then the patient goes to NCAP. This is called West Haven class encephalopathy class C, grade C. Type C. Type B is because the liver may or may not be dysfunctional, but the liver encephalopathy has occurred because of bypass. That's why B. Bypass, that is portosystemic shunting has occurred somewhere, or some bypass has occurred somewhere, or patient has undergone a TIPS or something like that, which has caused the entire nitrogen waste products to unload into the systemic circulation, leading to encephalopathy. So type B is because of a bypass, and type A is actually acute liver failure. Type A, type B and type C encephalopathy. Clear? So what would be this person that was there?
Type C.
So type C encephalopathy. That would be type C encephalopathy. Right. Now, this is the types of encephalopathy, but you will also need to grade them. Grade the encephalopathy to a severity. Right. To grade it to a severity, you have many classifications. Okay. What she mentioned is what you should look at: euphoria, lethargy,
Somnolence.
and coma. Simple. Euphoria, lethargy, somnolence and coma as the rate of encephalopathy keeps on increasing. Class 1, grade 1, grade 2, grade 3, grade 4 encephalopathy. And why you should know this? You should know this because this criteria, this euphoric criteria is grade 1. Once you reach 2 and more than 2, you should also add your GCS. So we should talk like this. This is class 2 encephalopathy with GCS or so on. So you should add both of them together so that we know where we are standing. Okay, here we don't add GCS. Here we add GCS. The defining point between this and this, can anyone tell me the defining point? Euphoria, lethargy, somnolence, coma. It seems like it is simple. But the differentiating point between this and this is actually time disorientation. Time disorientation. So here, you will have an altered sleep-wake cycle. But here, he will not know it's morning, he will not know it's night. So the question that you have to ask in this case is, kya hai? What is the time now? Is it morning? Is it night? So time disorientation comes in this side. Temporal dissociation is called. So temporal dissociation starts occurring from grade 2 onwards. And that is why these grades are supposed to be higher grades. Okay, grade 1 no, is only euphoria. Patient will just behave a little bit odd. You will have an altered sleep-wake cycle, but you would not consider that to be abnormal. That is why in order to actually put this, in order to actually subclassify this, you actually use psychological grading. Neuropsychological testing. So if a patient is in grade 1, no, neuropsychological testing is done. I don't know whether you know this, it's called an animal screen test. 60 animals are shown and they are told to talk about those animals. What is this animal? What is that animal? What is that animal? Okay, 60 animals are shown and they are told, and based on that they give them the screen, the tool. Okay, so neuropsychological testing occurs here. Bedside, how do you understand both of this? One is temporal segregation and the other is addition and subtraction function. Very often, here the addition function is gone. You see me sometimes talking, na? And this is subtraction function. So what happens is the addition function goes very often on euphoric patients on that side, and the subtraction function goes when they are down there. Okay, so clinically it is you would probably look like this. Clinically, their reflexes are actually exacerbated. They are increased. Okay, deep brain reflexes are more. You might think that this is less. It will be more actually. Okay, so euphoria, lethargy, somnolence, and coma coupled with GCS once you go beyond equal to 2 or more than 2. So this is class grade 1, grade 2, grade 3 and grade 4. Okay, this is very important for you because this forms as a part of your liver transplant program, King's College criteria. So class 3 and class 4, once you are in grade 3 and grade 4, that is one of the criteria for non-paracetamol poisoning criteria for transplants. Okay, to remember that what you normally say is pH is 7.3, that is fine. But more than that, what do we say? If the creatinine is 3.4, more than 3.4, or grade 3 and grade 4 encephalopathy. INR. 6.5. So the INR more than 6.5 100 seconds, or creatinine of 3.4, more than 3.4, or grade 3, grade 4 encephalopathy. In non-paracetamol poisoning, no, this criteria will come in place. Clear? Clear on this? King's College criteria. So in that grade 3 and grade 4 comes. That is why you should know grade 3, grade 4. Okay, very importantly. Clear?
So reflexes you said will be
Exactly, it is increased. Deep brain reflexes increased actually.
up to grade 2.
Yeah, it goes higher. It goes very much higher because NMDA receptors are working excessively. Okay, so it goes high. So it is also in this phase. So very often at this stage you also look at something called as asterixes, right? What is asterixes? What are asterixes? We call it as flaps, right? So these are the same things only. There are many movement disorders that occur in ICU, but it is not specific for this. That's why we don't. Where is it written over here anywhere? Is it written mentioned anywhere here? It's not, because it is so sensitive that it can change with metabolic problems, simple hypoglycemia, just with medicines, just with opioids. You give opioids to a person, by afternoon his flaps will start. Just with opioids it can come. Tramadol can cause flaps. You know, it's very sensitive kind of marker, which basically means how do you do, if tomorrow I want to do flaps, how will you do it?
Ask the patient to sit.
And then
and, keep the hands straight
and
look for around 5 to 10 seconds.
30 seconds. It is for that is why I want to hear what you're going to say. Usually, when you want to look for a class, you have to wait for 30 seconds. Why? Because what does this mean? Sustained voluntary muscle action is not possible. When you say sustained voluntary muscle action, means this is my sustained voluntary muscle action. Okay, for 30 seconds I can hold it like this. If I cannot hold it for 30 seconds, then I flap down, means I am losing my sustained voluntary muscle action. Okay, and that you have to do for a total of 30 seconds. Clear? That you have to do for a total of 30 seconds. So hepatic encephalopathy or any kind of that can derange with anything. It can be uremia, with just hypercarbia, just with hypoglycemia, just with opioids. It can do with anything. All those things. Those flaps can change can come with any of these manifestations. But once flaps come, something is wrong. You need to do something. Okay, it's like that. That's why flaps don't figure out here. You understand? That's why flaps don't figure out over here. You're not getting the point. You get out everything else, but you don't get flaps here.
So this criteria is all of them together, no?
Yes.
All
Yes. Yes.
Not either. All of them.
All. Okay, that is if the INR is not high, then this thing comes into place.
First one is the major criteria, less than 7.3 is the major criteria. That single criteria is sufficient. sir.
Here,
These
just
are minor
this,
criteria.
this is just enough for you to transplant. You understand now? That is just enough for transplant, whereas this one you require to, this is a minor criteria, that's why you have to have 2 out of the 3 at least. Okay? But mostly now, this all comes together only. Very often it all comes together. ये ऐसा कभी भी होता नहीं है कि भाई everything they come together, they normally come together. Right, so we've now discussed what the types of hepatic encephalopathy you have. You have understood what are the types of acute liver failure you have. You have understood the grades of hepatic encephalopathy. You have understood what ACLF is all about, acute and chronic liver cell failure. You understood that also, right? Any doubts till now? Any doubts till now? No, right? Now, what we are talking about here is what you must understand in acute liver failure is the problem that it actually creates something like a SIRS, a systemic inflammatory response syndrome, just like how pancreatitis does it. Similarly, ALF does the same thing. It causes SIRS, systemic inflammatory response syndrome. So you might ask, we started by saying we give these patients prophylactic antibiotics. The reason to give prophylactic antibiotics is the fact that it creates a SIRS which is very, very severe and it causes gut translocation of organisms. That is, it causes the release of something called chemokines. These chemokines causes pathogen associated molecular patterns to come out, damage associated molecular patterns to come out. And our liver is one of the main organs that are responsible for taking off these toxins and these bacteria out. It's not occurring anymore. So since that is not occurring, the gut barrier is not there anymore. The translocation of bacteria is occurring. That's why these people have got a very high chance of developing an infection. Very, very high chance of developing an infection. So very often than not, these patients, that's what spontaneous bacterial peritonitis is about. They are developing, how they are developing SBP? They are developing SBP because of this reason only. They are transuding and translocating the organisms and causing SBP. Similarly, any patient, that's why any patient who comes with esophageal varices, it's not wrong to put the patient on ceftriaxone or 1 gram BD for 7 days, though they don't have any infection. Are you understanding? If a patient of cirrhosis with variceal bleed comes to you, upper GI bleed comes to you, what is upper GI bleed?
Ligament of
Ligament.
So anything above the ligament of trees is upper GI bleed. And how do you identify upper GI bleed?
Dark color, saturated.
Any hematemesis or coffee ground vomitus is upper GI bleed. What is hematochezia? Hematochezia?
The blood mixed with the stools.
So what does it signify?
This lower GI.
It is kind of a lower GI, fresh.
Can it come from the right colon? So can it come from the small intestine? So more often than not, 90% of the times when there is hematochezia, it is going to be a lower GI bleed. However, when the transit of blood is very fast, even the upper GI bleed can show as lower GI bleed. If the transit of blood is very fast, even the upper GI, right colon, everything can actually be also be hematochezia if the transit is very fast. Okay, the transit is very fast. Clear on this? Huh? So now we've understood why patients of esophageal varices require an antibiotic, because they are actually decompensated liver disease, and decompensated liver disease per se is responsible for causing these activation of SIRS all the time. Okay, so at this time there may be a chance of translocation of bacteria because there is a super added esophageal varices bleed that has occurred. That is why 7 days of ceftriaxone 1 gram BD is given to these patients whenever they are admitted for variceal banding or any kind of thing like hematomesis. Speaking of hepatomesis, what would be the should we go to hepatomesis or should we just continue this? We first continue this only. Okay. So where are we? A, B, C, 1, 2, 3, 4. We are at this. Okay. So what would be the management now that we know what encephalopathy is about? You know what acute hepatic failure is about. You know what ACLF is about. What would be the management of hepatic encephalopathy per se? First of all, encephalopathy. Once the patient gets encephalopathy, the chances of dying are very high, 50%. Okay, of this patient dying. So these again are further divided into two kinds of encephalopathy. It's called covert and overt. Okay, covert and overt. Okay, when you say overt, this criteria is all overt. Overt means it's very obvious. Overt is very obvious. So this is all overt. Okay, whereas this is covert. C-O-V-E-R-T. See, covert encephalopathy, overt encephalopathy. Now, overt is further talked about recurrent encephalopathy. When you say recurrent encephalopathy, it means you have got 2 episodes of encephalopathy in 6 months' time. Okay, more equal to 2 or more than 2 episodes of NCEF, such a NCEF that is occurring in 6 months of time. That is called as overt recurrent. Overt recurrent. Alright. And if you have encephalopathy that is, and he is not recovering between those encephalopathies properly, he is still going into this euphoria but not recovering. He is not recovering from that, he still remains cognitively declined and all these things are still occurring, then that is called as persistent. Persistent. So you have overt, you have covert, and you have overt recurrent and overt persistent. So these terminologies are there. So some gastroenterologist comes and talks about overt recurrent. You should know what he's talking. Overt recurrent, what is overt persistent? Clear? Any doubts till now here? Any doubts? Okay. So now once we come to overt or covert, okay, now what is that patient that we had over here? Among all these things, how will you classify that patient, Nikhil, now? You have to first put this and then put this.
Type C.
Type C, hepatic encephalopathy,
Grade 3.
grade 3. Right? Grade 3. And now if he comes back in, and what is he? He is over recurrent. He had NCEF some time ago. He had NCEF some time ago. And what was his cause of NCEF?
No, varicose bleeding was
What was his common cause? His history said that.
constipation.
Yeah, 5 days of constipation, 4 days of constipation. This is what he had. 4 days of constipation, and that is why patients of ACLF or patients of cirrhosis are advised to have 2 to 3 bowel motions per day. Patients who got hepatic encephalopathy in the past are advised to have 2 to 3 bowel motions per day. So today if that guy goes home and has motions only once a day, he has a very high chance of going into again hepatic encephalopathy. And that is the reason that we put these patients on a medicine that is called as lactulose. That is the reason we put this patient on medicine called as lactulose. You clear? So any patient of cirrhosis who has had an episode of hepatic encephalopathy would classify and would be a candidate for the use of lactulose. A very difficult drug. Lactulose, have you had lactulose, any one of you all? Have you had lactulose? So you should try to use that because you will remember in your entire life कि क्या होता है उससे lactulose से. Okay, what happens with lactulose? Huh? Why is of course she did talk about ammonia and how ammonia is causing the problem?
Causing blood and
How ammonia is causing the problem? Ammonia is causing the problem because ammonia gets into the astrocytes, converts it to glutamine. Glutamine causes increased osmolar load in the astrocytes, causes the astrocyte to swell, and that is why the distance between the vascular supply and the inner part of the astrocyte actually increases. Nutrient diffusion reduces, and that's why the patient goes down and goes into ICP, raised ICP, and things like that. Not only that, this osmolar load being high, it actually interferes with ornithine transcarbamylase. It's a urea cycle which actually causes an increased amount of nitric oxide. Now, because of this nitric oxide going up, that's why there is vasodilatation in the brain, which actually causes the cerebral ICP to go up. Clear? So, and third is tyrosine, phenylalanine, phenols, mercaptans. They are not detoxified by the liver. They enter into the brain and causes GABA receptor activation and NMDA receptor excitation, causing problems, ICP. So multiple mechanisms are there which are causing the ICP to go up. Clear on this? Clear? Now the question that comes is, how does lactose work? How does lactose or lactulose work? Huh? So we just said one of the prime drugs we have for encephalopathy is lactulose, and the dose of lactulose that you have is usually, so if a patient comes in acute encaph to you, comes in encephalopathy to you, the dose would be
45 ml per hour till they open.
30 ml per 30 to 50 ml per hour
Till they open.
till he opens the bowel. Till he opens the bowel. Once he opens the bowel, reduce the dose. Okay, then you reduce the dose. Then you reduce the dose and then you can change it. That is one route. The one route that you can give is the oral route, or the route through enteral route. The other is the rectal route of lactulose. Okay. Now, how does lactulose work?
Increases the bowel transit and reduces the ammonia absorption, acidifies the bowel movement, and that acidification decreases the microorganism.
So from where is ammonia coming?
From the
From the
protein.
microbiome.
So if I don't have protein, I will not have ammonia. No, I'm just asking you because it's coming from protein. You're saying, so I'm keeping this patient NPM. I'm not really concerned.
Bacteria and
But micro-
Intestinal micro.
So the intestine has got a huge flora, right? So in that there are urease splitting organisms, of which commonest are Enterobacter, is bacteroids. These are all urease splitting organisms which are there inside the abdomen. They are responsible for creating ammonia. Not only that, the body has got a protein content. Even if you don't eat protein, the body has some protein that it produces. That protein is degraded to amino acids that forms ammonia. Okay, but what normally occurs in normal situation, this ammonia goes into the liver, gets detoxified. Normally all of us produce ammonia, that's the smell we get. Okay, but then that gets detoxified, and once that gets detoxified, things are all okay. That's how it is, isn't it? Detoxified. What is happening over here is liver is unable to detoxify that. Okay, liver is unable to detoxify it, so it really doesn't detoxify it, causing this ammonia to get unloaded into the systemic circulation and then getting into the brain. Clear? So that is a problem with ammonia. So how does lactulose work? So lactulose per se is basically two molecules of carbohydrates which are joined together. Okay, there are two molecules of two complex carbohydrates that are joined together. Okay, that's why it's called a disaccharide. It's called a disaccharide. It is joined together, but the bond is so strong that these gut enzymes can't degrade them. Otherwise, तुम कल दूध पियोगे तो तुम्हारा गट एंजाइम उसको डिग्रेड कर देता है. सो जिसका दूध जो बंदा दूध पीने के बाद उसका एंजाइम डिग्रेड नहीं करते उसको हम लैक्टोज इंटॉलरेंस बोलते हैं. हाउ डू यू डायग्नोज? हाउ डू यू ड्रिंक मिल्क? यू ड्रिंक मिल्क, द बॉडी इट गोज इनसाइड, माय गट एंजाइम्स then degrade, break down that sugar, and then it gets absorbed. Carbohydrates, complex are taken up, and you get healthy and things like that. What happens to a person who is lactose intolerant? A person who is lactose intolerant, what happens to him? This gut enzymes are unable to break down that milk, and so that milk reaches down there. It reaches down there and then causes catharsis. It causes catharsis. That's why a lactose intolerant person, when he takes dairy products, he starts getting diarrhea. Clear? He gets diarrhea. Similarly, what is happening over here with lactulose? Lactulose has got two molecules of these carbohydrates which are bound very, very strongly. Since it's bound very strongly, it cannot be degraded by the normal enzymes. It cannot be degraded by normal enzymes. It goes up to the gut, down there. It goes right up to there, and thus because it reaches there, it creates a high osmolar load down there and creates evacuation. It creates evacuation. And because of that, because of this evacuation, patient's entire bowel gets cleansed off. You understand? So it's a non-absorbable disaccharide which reaches the gut and causes an evacuation, and by usual things it will remove off all the organisms or whatever is there inside our body out. Okay, that's what it occurs. Second thing it also does is lactulose will actually convert itself to acetic acid. So since it converts to acetic acid, it is going to break down. After going there, it will be then broken down. After going there, down there, then the gut microorganism will start working with it. इधर तक तो गया वो, उधर तक enzyme को कुछ नहीं, enzyme cannot do anything. but then it reaches down and then the gut microbe starts working on it. When the gut microbe starts working on it, it actually converts to acetic acid and thus donates that one hydrogen ion. Now that's why NH3 becomes NH4 and starts getting excreted out. NH3 becomes NH4 because it donates that hydrogen ion and ammonium is created from ammonia which gets excreted out. Right? The third thing what it does is this entire load has gone down. अभी तक gut को कभी भी इतना carbohydrate मिला ही नहीं है. Everything gets absorbed right over here. Your abdomen, your stomach, up to the first part of the intestine, everything is already done. Covered the loss. Suddenly what has happened is the colon has received a huge carbohydrate load. Since the colon has received a huge carbohydrate load, what is happening to these gut microorganisms? They start preferentially using up the disaccharides to take energy and do not metabolize the amino acids. Because of which there is no production of ammonia. Clear? So what happens because of this? The entire thing, because of all these things, what happens? Ammonia production is also coming down. And the fourth thing is, because there is huge amount of carbohydrates that are coming, these bacteria are not able to live. These bacteria, Enterobacter, bacteroids, who don't require, not based on carbohydrates, the good bacteria starts growing. Lactobacillus. Lactobacillus is a good bacteria that starts growing in preference, in place of Enterobacter and bacteroids. Beautiful, no? So everything works together. This is all the proposed mechanisms, okay? These are all proposed mechanisms, okay, of lactulose. But that's how lactulose works. So the ultimate objective is to somehow ensure that the gut gets cleansed. That is why you may also want to use Pegleg. Pegleg? What is Pegleg? Pegleg we give for colon preparation, right? Polyethylene glycol. It is given for preparation of gut. Right, it is there for preparation of gut. It's a very simple thing that you can give for preparation. But the problem is, when using Pegleg, you are supposed to use 4 liters. The studies for hepatic encephalopathy is based on 3 to 4 liters of Pegleg. Are you understanding? That's why we tend to not give Pegleg. Because you can't really give 4 liters and create this evacuation. But otherwise, essentially you can use Pegleg also. Because it's going to cause the same effect actually. Apart from that's why we don't know how it works. Cleanse the bowel. And to cleanse the bowel, that is the way to do it. So, in acute liver failure patients who are in grade 1 and grade 2 encephalopathy, grade 1, grade 2 encephalopathy, who's fully conscious, obeying commands, talking to you, but only as sleep-wake cycle changes, people may say give them Pegleg. Why give them Pegleg? Because this now causes a lot of flatulence. It causes flatulence because what is happening? It is actually causing the release of acetic acid, acetone, and causing the entire intestine to dilate. That's why you have barbarically. You hear, no? When you give patient lactulose, you hear the sound. Patient tells you next day I'm having hawa bahut ja raha hai mera. Gad ho raha hai. It occurs. So next time you take lactulose, you realize this. It causes barbarigmy. It causes the gas formation inside. Okay, so it's very difficult for taking. Because Pegleg is what you just take it and you're done, evacuated. You evacuated large bowel. The issue is here when you're evacuating 4 liters inside, you will have electrolyte abnormalities. You understand? So you need the patient to be very conscious enough so that you can pick up those abnormalities. If the patient is conscious enough, he feels tired, no, he's feeling drink water, jaldi pani pi lo. He'll be able to coordinate with you. Here this patient is normally the ones who are not coordinating. The ICU what we get are the ones who are not coordinating with us. We have to do everything for them. Clear? Pegleg versus lactulose. So one of the prime therapies when we have hepatic encephalopathy, and that will all this measure will work only when there is type B or type C encephalopathy. In type A, for example, you have liver failure or encephalopathy or high ammonia as a result of paracetamol poisoning. This lactulose is not going to work. It's not going to work. Acute liver failure, patient needs supportive management. Whereas in chronic liver failure or type B or type C hepatic encephalopathy, you can still have this drug called as lactulose or Pegleg. Clear? Any doubts till now?
So Pegleg can be used in where there is fluid restriction.
You can't know. That's a problem with Pegleg has got its own set of problems. That's why I said that person one जो एक ग्रेड 1 है न्यूरोसाइकोलॉजिकल टेस्टिंग में उसको पता चल गया कि इसको एनकेफेलोपैथी चल रहा है, आई डोंट वांट हिम टू प्रोग्रेस टू ग्रेड 2 एंड ग्रेड 3, देयर इज अ हाई लाइक्लीहुड दैट ही विल प्रोग्रेस, लेट मी गिव हिम पेगलेग, he will evacuate quicker and probably get better faster. He is conscious, he will be able to drink water, he will be able to get better on his own only. समझ में आ रहा है? हाँ? So in acute hepatic failure, in patients of type A, in type hyperacute, and patients very conscious, that is the place where you will use this.
So then the Movicol sachet, that is also says.
Same thing only it is. It is the same thing only it is. It's a purgative. Like these, yesterday I was talking to somebody who was talking about. So the other listen. So there, when you say retention, so this is the exact principle is the same only, because sometimes what does happen is lactulose you might give, the transit is very slow, it might not reach the gut. The entire point is somehow to avoid that intubation. Okay, let them get up quickly, because otherwise you will aspirate. Why do they die, these patients? No, they die because of multi-system organ failure. They don't die because of aspiration. The commonest cause of death in these cases is multi-system because SIRS, like pancreatitis. The second cause is aspiration. The first cause is always multi-system organ failure. They develop another organ failure. Right? So that's why there is no classical definition for ACLF. In ACLF, they define saying that there is some problem with the liver plus there is a problem with another organ. That is ACLF. You see ACLF, it's not like acute or chronic kidney disease. It's not like acute or chronic disease. Acute or chronic kidney disease में क्या होता है CKD है patient को फिर acute problem आ गया है and you define it that way. ACLF is not like that. ACLF is you have a chronic problem, but there is an addition of one more organ failure or organ insufficiency. For example, a person has come in, he has got pre-existing cirrhosis, now develops renal failure. He is a patient of cirrhosis, he develops respiratory failure. He develops coagulopathy. All these things are ACLFs. Clear? Clear on this? You have another organ failure. So there is no defined definition for ACLF. Okay, there is no defined definition for ACLF. Clear on this? But ALF has got a definition. ALF definition says INR more than 1.5 and encephalopathy. In pre-existing, no liver problem.
So liver congestion can be taken as a pre-existing?
No. So, but acute liver failure can be caused by acute RV overload. Okay, congestion is not acute RV overload. For example, you have pulmonary embolism. If you have pulmonary embolism and somehow you are managing this patient with pulmonary embolism, the back pressure can cause acute liver failure because of extreme elevation of SGOT, SGPT, also because of vascular pathologies, which is calling ischemia. Okay, so that is also coming in place in this acute liver failure segment. You understand? They can go to liver cell failure. That's why sometimes you see patients CPR, VPR kiya, SGOT, SGPT is like in 5,000s and 10,000 ranges. Is ischemic hepatitis, right? Ischemic hepatitis. So that is congestion, hepatitis caused because of that. So that per se will also require the NAC regimen that we are thinking about. Clear? So have you understood lactulose? The first.
Can you please explain the first point of lactulose? You said that the large amount of lactulose goes down there.
Yeah. So it is not getting enzymatically modified. No. What is normally occurring? When you eat anything, no, it gets enzymatically modified by your gut enzymes. This is not getting enzymatically modified because it's got a very strong bond between both those between those carbohydrate molecules. So it goes down, it goes up till down, and then the gut microbes work on it. The enzymes are not working on it. You know, the microbes working, the enzymes are not working on it. Reach is still there. So if a person of liver cell failure is there and he is lactose intolerant, just give him dairy products. He'll be okay all his life. The other way around, you understand what I'm saying?
Lactose is like lactulose for them.
Lactose. Lactulose for them, lactose जैसे lactose होता है उनका. So for them, what they do? You just give them dairy products and they'll be okay all their life. So if the person is lactose intolerant with the presence of liver cell failure, just give dairy products and he will be okay. He will be okay. Why? Because you have pushed the same lactose inside which is intolerant to. The same thing is occurring which occurs lactulose. हम लोग lactose intolerant नहीं हैं, इसलिए हमको lactulose लेना पड़ रहा है. If we were lactose intolerant, I would just take some dairy products, just some milk every day, just have some yogurt every day. It's completely clear, simple. Logically, you understand that? It's so simple it is. Right? So that's the first thing we talk about. The second treatment that we can think about is about a non-absorbable antibiotic. a non-absorbable antibiotic. Just like this, there are non-absorbable antibiotics. Okay, and the non-absorbable antibiotic that we know of is rifaximin. The first antibiotic that they used initially was actually an antibiotic called as neomycin. Even I have used that in the past. Neomycin. Okay, neomycin was the first antibiotic because it was non-absorbable. It was non-absorbable, and that is the reason that you give that antibiotic, it goes inside and it completely changes the gut microbiome. It takes off all these organisms. But luckily, the lucky part of this non-absorbable antibiotic is that it does not take off the good organisms like lactobacillus. That remains. But bifidobacterium, that remains. But bacteroid, enterobacteria, all that it comes off. All the urea splitting organisms come off. Are you understanding? Huh? You understand that is moved off. That's why rifaximin and that is neomycin. Now, somewhere in 1900s, the rifaximin also came. Neomycin caused its own set of problems. It was causing problems with respect to creatinine and other problems. It was creating resistance and all these things it was creating. What happened with with a company called Norgen? Norgen actually took rifampicin, normal rifampicin, and added some bond into it and made it non-absorbable. And that is the birth of rifaximin. Okay, Norgen करके एक chemist एक बहुत बड़ा just like Pfizer, there is a Norgen करके there is one group. They created this rifaximin, which has been a boon to everyone. So rifaximin came in, which became non-absorbable. So now rifaximin you give to the person, the rifaximin goes all through the gut, reaches the colon, and then completely clears the colon from the urea splitting organisms. It completely clears the colon from the urea splitting organisms. You got the point? Huh? That's how rifaximin works. Non-absorbable antibiotic. And the good part of this entire story is it doesn't cause resistance. It doesn't cause resistance mechanisms. For some reason, it doesn't cause resistance mechanisms. It doesn't do that. You understand? It doesn't cause. We always think, you're giving an antibiotic, it will cause resistance. It doesn't cause resistance mechanisms. That's a good part of the entire story about rifaximin. Right? So where will you use rifaximin? So usually that's why you need to know overt and recurrent and persistent. So when you say covert, you will use lactulose. When it becomes recurrent, you will add rifaximin. That means in 6 months time, if he has 2 episodes, of hepatic encephalopathy, not only will I ensure 2 to 3 bowel motions per day with lactulose, I will also put him on a long-term rifaximin for how much of a years he's alive. You understand? So Rifagot becomes a routine for that particular person because he's had recurrent for example, that patient on discharge should receive rifaximin. On discharge, he should be on rifaximin for entire time that he has because he has gone to recurrent. That's why you should know what is recurrent hepatic encephalopathy where the management changes. Here, rifaximin does not change mortality, does not change incidence of hepatic encephalopathy. All that rifaximin does is changes quality of life. Clear? So don't think that मैं rifaximin दिया इसलिए उसको encephalopathy नहीं हो रहा है. नहीं. Encephalopathy और mortality में कोई relation ही नहीं है rifaximin का. Rifaximin only causes improvement in quality of life. This is what most of the studies have said. Some subgroup analysis has shown reduction in encephalopathy, but the major studies have actually said it actually improves quality of life. Okay, clear on this? Clear? It just changes quality of life. So if
the neurologically patient is improving, then we'll not give rifaximin. Is it like we have to give it lifetime or not?
Lifetime.
But if he's not having episodes of encephalopathy,
He's had. That is why you're giving him. He has had 2 episodes in 6 months.
yeah, but afterwards, when he is on
Rifaximin.
lactulose and rifaximin, see,
I will continue it
he
lifelong.
was-
Lifelong. I will continue the lifelong. So
That recurrence rate will come down?
no, it will not. It doesn't change. That's the point. So it's not this way. Ki rifaximin you give and his hepatic encephalopathy will come down. It's not like that. But his quality of life is improved. See, this is all from studies. It's all from studies. We cannot say that it is not doing anything to the encephalopathy. I don't know. But studies have said that it actually causes a reduction in improvement in quality of life. Now, quality of life can be think of admissions to the hospital, chances of repeated SBPs, variceal bleeds. There are so many things that are there involved in quality of life. It's quality of life doesn't mean I'm going for a drink. Quality of life means all these things: repeated hospital admissions. I'm feeling better. I'm passing motions better. I don't feel sleepy during the day. I am actually doing my work. I don't have cognitive disabilities. I can read this very simply. I understand what is written over here. These are all quality of life parameters, right? So these quality of life parameters actually get better when you actually use rifaximin. There are some subgroup analysis that actually says reduction in hepatic NK, but there's subgroup analysis, so we really don't think about it that way. Clear?
So rifampicin has effects on liver.
Yes.
So
That's
rifampicin
why they
now it
did
is
this.
It
not-
does not have anything because it is not.
because of change.
It is not going there. No.
It is not absorbed.
It is not getting absorbed. It is going from there directly into the gut, into the colon, and working right down over there. Beautiful drug, actually. I would say it's a miracle drug that they made, and the company that made it, it's a fantastic company, Norgine करके company that they made it, and it's a fantastic product. I feel it's cheap product and improves quality of life. These are products that you feel proud of, that we as human beings we made such products, isn't it? So rifaximin. So when we talk about enemas here, retention enemas, this is a very different thing. What is the retention enema? I explained to you. I don't think anybody else knows. Okay, what is the retention enema? What is an enema? How does an enema given? How is an enema given? Anybody? How is an enema given? So yesterday who was discussing with me? You and only you and you. Okay. So how is an enema given, Arshad?
through rectal route.
How? That we know rectal route. How? You see, any procedure done in the ICU, you should know it inside out. Yeah, it is very essential because this is your life. So when you are working over here, you should know what's happening. It's important. If you don't know what's happening now, then it's not good for you. You should know it. So how is an enema given? Vidya, can you explain to everyone?
So there in PC enema there is one.
So what is PC enema?
Proctoclysis.
Proctoclysis enema means what? It is actually a sodium phosphate enema. So enema, when you say PC enema, is a proctoclysis. It's a process of cleaning the proctus, that is the rectum. Okay, that's why it's called as That's why it's called as proctoclysis. That's why it's called as proctoclysis. Sodium phosphate is one of those enemas that we use for evacuation. But retention enema is completely different. Retention enema is, I want lactulose at that particular place. I want it for a long period of time so that it works on these organisms. It works such that it causes evacuation of the bowel. So I want it to be inside the gut for a long period of time. That's why it's called as retention enema. Retention enema. So for a retention enema, how do you use it? So when you open up a lactulose kit, an enema kit, Dufelac kit, you see there's a big dabba that comes. You've seen that? There's a big dabba comes. Oh, dabbe के अंदर क्या होता है?
Bag रहता है with
Tubing.
and you have to mix.
और एक bottle होता है.
Bottle.
So a Dufelac enema retention kit has got a box in which there is a bottle of 300 ml of lactulose, and there is a bag that has got a marking of 300 and 700, 301 liter. Okay, what you do in this case, they clamp it, they give the patient a Sims position, that is the knee chest position in the left lateral position. Okay, and subsequently they fill this bag with 300 ml of Dufelac. The whole container is emptied into it, and then another 700 ml of normal saline is passed into it. Normal saline or tap water, what do we want? Tap water you can pass into it, warm water. Okay, you pass that and you fill the bag. You close it, apply it around 18 inches above the anal verge. 18 inches above the anal verge. It goes at least 18 inches above the anal verge. Okay. And then at the tip of that there is a small nozzle. A small nozzle. That nozzle is lubricated. And then after the nozzle is lubricated, first they actually do a per-rectal examination. They find that area whether it's okay or not, anal verge, because the first thing that will happen is your sphincter will get tight, so it's contracted. So you first lubricate that area properly. Then they pass that inside. Once they pass it inside, the rectal sphincter will actually relax a little bit after lubricating, and then this entire 1 liter is passed inside the abdomen. Okay, it's passed inside the abdomen. Once it's passed inside the abdomen, the patient is kept in the Trendelenburg position for at least next 1 hour. 30 minutes to 1 hour you can keep the patient in the Trendelenburg position. Once you keep them in the Trendelenburg position, then you can actually just open the clamp and let the whole thing pass, or tell the patient to evacuate. The enema tube is inside, right? More often than not, the patient evacuates. Clear? The patient evacuates because of all the effects that enema has. Clear? That's what a retention enema is about. Any questions on retention enema?
So for how much time that is clamped?
So 30 minutes to 60 minutes. Either you can keep it for 30 minutes, 40 minutes, 50 minutes, or 60 minutes. Keep it for that time. It has to be kept for long. Why? Because you want this lactulose to work there. No. If you put it inside and take it out, is the lactulose going to work? No. You need some time for the lactulose to be there. So lactulose, you keep them for around 30 minutes, 40 to 50 minutes till the lactulose works on that gut and creates the effect that we have just now discussed. To create that effect, it is going to take some time. That's the retention enema that we give.
And is there time specified for that whole 1 liter to reach inside?
No, it has to just go inside. It just has to go
So
inside.
after it goes into we clamp it.
So very often what happens, sorry, what happens is that after 5 minutes, patient starts saying I don't want anymore. Patient बोलता भी है because वो full हो जाता है इससे. Intestine कभी-कभी full हो जाता है, doesn't distend like they're supposed to distend, and they start saying no, it's full. So then you have to do it in 2 sittings. लेकिन 1 liter जाना है. What were you
So
asking?
after it goes into after we empty it 1 liter, we'll keep it clamped in for 1 hour.
Yeah, 1 hour we wait. We wait and then you tell the more often than not you tell the patient to evacuate. Patient will be able to evacuate because it's loaded, it is fully loaded. Patient will be able to evacuate. Also, it is being helped by the entire gas formation that is occurring and all those things are occurring. Patient will be able to evacuate. You understand? If we not able to evacuate, then what we do? We actually open up the clamp and whatever is gone inside, we take it outside. Clear? So this is done around 3 to 4 times in a day because we want 3 to 4 bowel motions. That's why it is done 3 to 4 times a day. Clear? Any queries?
So I just wanted soap water enema, sir. I mean,
What?
so how it is like safe or like they take tap water, they are taking soap from.
That's okay. It's after all the most dirtiest part of your body, no? So soap water enema is for what? It is actually in Ayurveda. It is almost. It is actually what is it called as? Ayurveda में क्या बोलते हैं इसे? Basti. It's called basti. Something is called. People do it every day in Ayurveda. They believe that it works. It works, and I think it works. Okay, I personally feel it will work. Okay, why should it not work? Because these are all organisms and need to get out of the body. Okay, it will work. As long as you pass motions properly all through your life, you will be healthy. The day you reduce your motions, that day onwards you will start feeling bad. And that is what we see also. We see it regularly. An old age person doesn't pass motions, they start feeling bad. Okay, so Basti is not wrong. I think it's right only. And soap water enema is known. We cannot give proctoclysis enema to a person who has chronic kidney disease and renal failure. Why? Phosphate content is very high. It will cause hyperphosphatemia. Are you understanding? 10 gram phosphate is उसके अंदर. It will cause problems. It will cause hyperphosphatemia. So that's why we don't want to give proctoclysis enema to a patient who's in CKD, which is a very wrong thing to do. So we give them soap water enema. In soap water enema, what do? We just give them water. You may want to give whatever you want. You can give Bisleri also if you want. You can give tap water also if you want. कुछ फर्क नहीं पड़ने वाला है, हाँ? Because it's going into that colon. So normally we say filtered water. Use a filtered water. Hospital waters are usually all filtered. So filtered water, and you add 3 or 4 teaspoons or tablespoons of soap, mild soap. So you can't add an alcohol soap. You can't add maybe Lifebuoy. You can't add that. You'll have to add a very mild soap. You know, mild hand wash soaps होते हैं. That may be good enough. Huh? Sorry? Yeah, actually. So what one of my doctors, senior doctors, had told me long ago. He's not alive anymore, but he used to say take Johnson's baby soap, okay, and keep it in water all the time. He used to have in the hospital one Johnson's baby soap all the time in water. So that soap used to be taken. उसका 3-4 चम्मच निकालते थे पानी का, जिस पानी में डालते थे उसका 3-4 चम्मच निकाल के उसको डालते थे. Because liquid soap, actually the recommended liquid soap is Castile soap. Castile, Castile soap. Castile soap is a very, very organic soap. If you put on Amazon, you will get it. It's called Born Organic. Okay, you'll get it in Amazon. Called as Born Organic. It's called Castile soap. Castile soap is the one that we use. We use normal soap over here, which is very liquid soap that we have over here. We use that. Clear?
So this will just increase for how it will help the hospital.
Same. Yeah, it's just washing away. Say 1 liter goes in, 1 liter has to come out, no? It's washing, no? It's not going to be absorbed. It's 1 liter going in, 1 liter has to come out. So it is just cleaning the bowel. It's just cleaning it.
Then irritable bowel.
It will not cause any irritation. The colon is ready for receptive to take all this, na? And then it will take it out.
Volume is same, 1 liter.
1 liter. No, 1 liter. Evacuant enema, this is called. This is called as evacuant enema. So when you have enemas, they can be in the therapeutic enemas regimen. You have evacuant enemas, which is proctoclysis enema is an evacuant enema where you put it inside, it causes some distension and it evacuates. The other enemas that we have is retention enemas. So now, you want to break now or should we just finish it off? We can actually finish it off. I have to go somewhere. I have to go for some work. Finish it. Okay. So just ये करना इसको जरा clean कर देने के बाद. So now where are we? We are at retention enema हो गया, रिफा कट हो गया ना treatment में. I'll just make some coffee. So we did start the whole story by saying you have got INR that is more than 1.5. We started like that. We started by saying that the INR is more than 1.5. Now, what do you understand by what happens in cirrhosis? Now, we are in the domain of cirrhosis. Okay, don't confuse this now. Cirrhosis or chronic liver insufficiency or chronic liver failure, whatever we are talking about is that cirrhosis, where the liver is spoiled. Okay, it's different from ALF. Okay, its liver is actually essentially spoiled. So let me give you a case scenario. You have a patient that has come in with a hepatic hydrothorax. That means he's got a lot of fluid inside the lungs. He's got a huge ascites that is there. Huh?
I just want
Huh?
to add two things.
Huh.
Like,
Huh, no, no.